Right, so this is almost a rant on working with health and social care data for about 10 years. I had no intention of ever working with health data when I started my bachelor degree in statistics. I just liked methodology and had interesting statistics, and then I came to the UK to do a PhD here in Durham, working with 3D seismic data, so looking at essentially oil exploration and gases and so on. That was fun. And then I moved to a project called Tipping Points that was funded by the Leverhulme Trust, where I met probably too many people, but very interesting people overall, and some of them with more interested in social behaviors and health and so on. And then eventually my first health project became a project that's went on until just before COVID, and hopefully will resume just after that, looking at cardiac patients in the University of South Manchester. And essentially the cardiac surgeons had approached us. They wanted at first to look at surgeon performance, and then that became a project looking at real-time treatment and monitoring of patients and so on. So that's where health started in my life, so about 10 years ago. And since then, I think I was quite happy to do health research, especially data health research back then. And then I really became an academic, and I'm still happy to do the work, but there's so many things that need to be fixed that I think most of my life from now on will be about fixing things rather than actually doing the work. And that's probably to help set the environment for new researchers that are coming up and want to do the best they can. So what I did was I grabbed the questions that Nick had sent to us, to David and I earlier, and broke down in sets to look at how they reflected in different projects that I've worked with overall. So the first set that I thought were more relevant is how can we get people to trust their data to be shared across the NHS and with researchers? How can we keep privacy and work with sensitive data? How can data privacy and patient safety be balanced? And can I ask for top tips for getting through on the first pass with utilization of patient data? Right, the problem with this one is it's not about, depends on who you mean by people, because your first hurdle aren't the patients. Your first hurdle is whoever holds the data, and that might be the NHS, an NHS trust, it might be NHS Digital, it might be your local authority, or a GP practice, and so on. So the first thing is you have to demonstrate that you are a trustworthy researcher to whoever you're going to work with. So a lot of the work is around stakeholder management. Essentially, forget the whole persona around being a geek, a nerd, or whatever. Work on your social skills. You're going to need it because most of the people that hold the data are politicians, and you need to be able to understand and work the system and build the trust around it. I wish that wasn't the case, but that's important. And that eventually translates on how patients perceive a trust around organizations and who will ultimately manipulate the data. Which then, of course, if you're working, for example, directly with an NHS trust, they'll have their own processes that reflect the processes that David talked about, and often more than that. And a lot of it is about assurance, governance, who's going to work with the data, what data, why do you want the data, who wants to know about these results, and so on. So most of my work sits on the realm of service evaluation or system improvement rather than direct research. I mean, I do have research related projects as well, but it's mostly around policy and system improvement. And in that case, it's about how and where the data needs to be used to improve the systems for everyone. And of course, consent and privacy sits very much on the foundation of that. It's not about the individual, but the system and how to improve the system overall. Okay, so the first one I'll talk about is one of the projects I worked on well, around 2015 to 2018, and that was part of the Darlington Healthy New Towns. So there was this initiative across the country where we were trying to identify 10 NHS Healthy New Towns, and the point was to try to bring together the councils, local authorities, to work together to create the best possible environment and healthy environment for citizens within those areas. Darlington is one of the few places where the whole county itself became a healthy new town in a way. And what they wanted to do is, how do we understand better what's going on with our GP services? Can we look at possibly reconfiguring the way systems are delivered? We have a bunch of practices that potentially work in a disjoint fashion. Do we need hubs? How do they integrate with the local trust and so on? So Darlington has a very interesting first geographical setting. You can see that almost all practices are around the city center, all around the hospital. So, and that's very much linked to the network, traffic network set up in Darlington. Everything goes to the middle, as it's true of many cities and towns around the UK. The focus is always the center, so which means that accessibility is decreased as you go out of the center. But also that means that deprivation tends to accumulate around the center. So the practices normally have a high, well, first, practice list size in Darlington are incredibly large, or at least some of them incredibly large, and a large proportion of the population is reasonably deprived. And for example, some of the stats here are based on 2017 and 15, where, for example, Clifton Court, who is now actually part of a different study at university, at Durham University, had the highest opioid usage in the country. So they were targeted for reduction and looking at tapering and other interventions that could be put in place to, well, first reduce the usage of opioid, but you can't just reduce it. You have to target and identify the interventions and the reason why overprescription is taking place. And then so on. There are a few other statistics that they'll be interesting later on. And of course, distance from A&E is actually a critical factor in terms of usage as well. So what we wanted to do was look at GP practice scenario planning, which would then eventually look at staffing, but distribution of services and so on. So we developed this app that was distributed to each practice, personalized to them, so they could have a taste for what their practice looked like and how their practice was actually being used, how the service was being used, and so on. So the main questions were, how would the population change over time, and how that would impact what we're seeing. If we, so we also worked with Bicester, not just Darlington, but the key is they were both being targeted for new developments. Bicester very close to Oxford, so it was going to be a really upper middle class development. There would be a very different makeup in terms of services needed, while Darlington, new homes, but it's unlikely that they were going to see immigration. They're more likely to see internal migration and even potentially immigration, because, I mean, up to, say, 2 years ago, no one really wanted to come to Darlington, but you could say that now with the Darlington Economic Centre and the Treasury coming over, that might change. But up to when that study was being run, Darlington wasn't exactly attractive. So the impact in demographic change would be very different for both settings. So there were very broad questions that were being asked. And part of the problem is, how do we do this and what data do we use to do that? So one of the points that David talked about was about anonymized and pseudonymized data. I was told quite early on by especially the trust I was working with, that forgets the idea of anonymized data. That isn't a thing really. If we're looking at single patients, then just start with the assumption that everything is pseudonymized, and treat the data as if everything was identifiable, because that's the best way you can ensure that you have the best security and assurance in place and governance. I think it's overkill, but I could understand why they were starting from that point, especially when 2017 wasn't far from the latest data breach in the NHS. The initial data sets we got for some of the practice were the full practice lists. They were fully pseudonymized. I'll talk about the pseudonymization process later. We also had appointment data, some details around long-term conditions and so on. So even if the NHS number was pseudonymized and we didn't get any more identifiable data about that patient, but once we put together long-term conditions, you almost can narrow down to a specific set of people potentially and even become identifiable. So there's always care to be taken. Even if the data is anonymized, it's not really anonymized most of the times. And then there was data that was already readily available. So for example, it's really easy to get access to practice list demographics on the NHS website, appointment rates and so on, because a lot of this is already regularly reported to the NHS and to the ONS as well in some instances. There are other data that aren't NHS data, but they're sensitive, like for example, the housing development data. We had access to all the sites where housing developments were being planned. For example, population projections, there was a lot of political political issues and definitely content around which projections to use, because the local authority, the trust, and the ONS were not in agreement on which projections were the correct ones. So having access to data doesn't mean you have the right data, and doesn't mean necessarily you have the data that your stakeholders agree with. I think the key of making sure that you have a successful project that for which your outcomes are going to be used later on potentially for policy change and impact is to ensure that you bring everyone together with you, and you make sure they agree with the processes you're using. Of course, they can't interfere with the actual modeling aspects and the delivery, but you do have to take everyone's opinions into account and come up with the best possible result. So part of that project, the main success, I would say, was the joint development of the approaches to address the health and social care needs for the Darlington population and the Bicester population to an extent. The council and the practice learned a lot about what was going on, as well as the trust. But I think the biggest success and the hardest part of the work was establishing new approaches for data sharing, the information governance management processes that we put in place, and ensuring legal compliance, and all the other mechanisms that didn't exist, at least within our university, and by extent, some other universities we did work with, processes to facilitate the collaboration between the trust, the practices, and higher education in general. Essentially, it was a nightmare, and it still is, but at least we know what the nightmare looks like and how we solve the problem. So I think that's something that most universities still have to learn, regardless of whether they have a medical school or not. It's not straightforward, and a lot of it is just providing the adequate level of assurance to ensure that what your researchers are doing is appropriate and will bring benefits to the stakeholders. So the main learning points, which some of them I would say are definitely in progress, and I see some of that reflected on NHS Digital and NHS, and a few different changes that are coming over the next few years. But one thing is need to improve understanding of information availability and resources. Yes, NHS Digital has access to a lot of patient data, but they don't have access to all the patient data. And sometimes it's the data that the practice think are valuable are not necessarily there. And when you look at practice data, every practice will have their own way of recording data despite having to use the same forms. So while coding can be uniform for, say, for example, certain conditions like diabetes, the usage of certain fields for recording isn't consistent. So don't expect the data to be nice. Never expect data to be good. Always essentially expect the worst, and then when you get your data, you figure out how to solve the problem around the gaps that you have identified. The second one, which I'm sure I know that NHS Digital and NHS X are trying to solve, it's the interoperability and over standards, which essentially go back to the first point I was pointing over there. In primary care, that's, I would say, quite good and almost excellent, I would say. Secondary care, it's a disaster. There's no commonality. Everyone uses a different system. You're never going to be able to nicely say that data X exists on trust Y, and the same reflects on trust Z. Everything is different on secondary and tertiary care. And then when you go to social care, it's a completely different nightmare to look at, but always go back. And it's actually a great exercise for anyone that's interested in actual data curation and data management, because you're never going to change the way they work, but you could influence how the data mechanisms for sharing and building new databases could work. And so a lot of what we've done revolved about differences in culture. There were plenty of times where it was clear that the local authority, the trust, and the university had very different targets. The funding mechanisms for all three are very different. Performance targets are definitely incredibly different. When you're talking about trusts and local authorities, you're talking about normally short-term targets, even though they do appreciate long-term targets. And normally that doesn't align with academic targets and research scales, time scales, and so on. So there's a lot to be understood there when you start a research project, especially one that can affect operations overall. So then if we move to the second set, how do you maintain data integrity during the anonymization process? How can we show population representativeness in data sets? How can we work effectively with lower quality data sets and make use of them as best we can? How does the national data opt-out affect what data can be used? So pretty sure David addressed the third one as well, as much better than I could. The thing that I did see is that while data opt-out is there, it's very low. And from PPI that has happened in other projects that I was part of, most people expected already that the data was being used to improve systems. It's not the norm to opt out. It's the norm to say, why the hell isn't my data being used to improve systems? Which is, I think, a quite positive way of seeing how patients expect the data to be used. Not necessarily want to be tracked and then someone knock on the door and ask why didn't you go to your GP checkup last week, but how can we improve systems overall so I have the best care, but also my family and so on. So for this one, it's a follow-up project that came sort of alongside the one I just talked about. And that was a requirement from some of the trusts in the region to better understand A&E arrivals. So each trust has a different way of handling admissions, data in particular, how to record arrivals in A&E and so on. But what everyone does have a problem with is they know when the high demand is coming. They don't necessarily have a good way of predicting it, but they absolutely know when things are going to go wrong. So they wanted essentially development of models based on that data that we could look at not just numbers, not just volume coming through A&E, but who's coming through A&E in different days, what's the type of admission to be expected, or if even how many of those are to be converted into admissions, and so on. So that was the point where I realized the secondary care is completely different. While Trust One will have a very specific way of recording data for the A&E arrivals, with coded information, say around ICD codes and treatment codes and so on. Trust 2 might be using a different set of codes, and you can't necessarily compare both of them until you fully sanitize the data. And sometimes it involves talking to the data analytics teams in the trust and understanding why they're using a different system and how do they use that data later on to ensure that they can comply to whatever quality standards they need to comply that they have built in. So never expect trust data to be the same. They're all different. So for example, one of the things they wanted to understand better was weekends and holidays. They knew that they had an increase, but sometimes there were some weekends that were worse than others. And why was that? And why couldn't they essentially predict that in the longer term to be able to ensure that they have the correct staffing levels each time? But also they would want to know what type of staff they need to be in place. So that's why it's important to understand what type of patients are coming through. Then you have, for example, in this case, effects of the weather, which is partially predictable. But the key is, for example, up to before COVID, winter plus a large elderly population like we have in the Northeast means increasing falls, which means that you're going to start seeing some people in A&E that you wouldn't have expected to see in previous months, and they almost certainly lead to an admission, which takes a bed. And then when you're talking about COVID, it sometimes takes a bed that you don't have, but also you have a patient now at increased risk of contracting COVID in hospital as well. When you look, for example, in Durham more specifically, university term time has a very specific effect on A&E, and in particular, our induction week. I mean, alcohol poisoning is high, not so much in later years, but that was one of the reasons for introducing an alcohol policy and so on. Payday is a brilliant day. You can see an immediate impact on A&E attendance, and then you have some interesting matches that you know will lead to increased attendance as well, and different types of injuries linked to that. So that's when we started looking at mostly aggregated data. So that project started with essentially counts. So we're not talking about patient level data just yet. We did have them aggregated in a way that we were still meeting the standards, so that you had at least 5 patients within the group, so it wasn't fully identifiable, but it wasn't ideal because it didn't help understand, say, for example, long-term conditions and other specific variables that were definitely essential for understanding what the behaviors around arrivals and admissions were. So we started with the very basic data sets of arrival dates and counts. Then we started adding things like arrival mode. Did they come by car? Did they come by bus? Did they come by ambulance? And so on. Then we start looking at length of stay and breach flags. That's when you hang around A&E far too long and the trust gets essentially fined because you waited for too long. Then you start looking at demographics, age groups, gender, and so on. And then you start understanding what the dynamic is around your population. And then it gets to the point where, well, now I need to know more about each patient, and I need to know how often they're coming back to A&E, for example. There's some trusts that see some patients 500 to 600 times a year. People just sometimes need extra care. Sometimes it's mental health related, but there are what they call high flyers sometimes. So you need to understand why people are coming back as well. and whether that's leading to deterioration in health. And then sometimes you might want to move to single age. So you're entering now identifiable territory. And when you enter that territory, information sharing becomes much harder. So, which means you have to give the trust a solution around pseudonymization. If you are sharing data with NHS Digital or NHSX or even your local commissioner, they already have that in place most of the times, but the trusts normally don't trust many others to handle the data, so they normally want to share the data directly, which means that you have to put in place the tools for sharing. Some trusts do have processes for pseudonymization, other trusts don't, and some trusts want you to handle everything. Especially in the Northeast, because we wanted to be able to see patients across different institutions, different trusts, different GPs, we needed a way to be able to identify the patient in terms of the pseudo NHS number that was in place, but the trust and the practice didn't want the other partners to know where the patients were going to. It was a very strange, bizarre politics of NHS not wanting to share data with the NHS, but happy to share data with universities. So we put the process in place and we built a pseudonymization tool that was used. That's the point where I thought this is just absurd. Why doesn't the NHS want to share data with the NHS? But that's probably a question for David and not for me. Anyway, so we found the solution to be able to move forward and actually use the data, get the full lists for A&E, and be able to understand what was going on. And then when we progressed a little bit further with the A&E data, one of the trusts came forward. See, we take all these measurements for all your patients when they arrive here. We take all the components of the early warning scores and we record that data. So the early warning score is a composite score that takes into account factors like your blood pressure, your heart rate, respiratory rate, oxygenation levels, and so on. So essentially, because you are required to record that when a patient arrives, and then normally every 4 hours after that, all the trusts are sitting in this massive data set that they don't necessarily know what to do with. So one of the trusts asked, can you do something with it? Can you take a look? Can we do anything better than what we're doing at the moment? We know that news doesn't necessarily work as expected. I mean, the main point of news, the National Early Warning Score, is to get people to record data. The score itself is useful to identify very extreme cases, but not so good to capture nuances on what's going on with your patient. But because you have to record the data, you have to look at the patient, and care is improved immediately because you're regularly checking on your patients. But then the question is, we have, so in this case, James Cook Hospital had 5 million recorded EWS components in all the wards, A&E, and so on. They also had all the patient-related data you would want, like age, ICD-10 codes, treatment codes, and in this specific data set, we're looking at just under 80,000 patients. So it's an incredible data set. Can we now understand better what's going on within the hospital? So one of the questions is, can you establish a score? Can you help us understand what the current health state of the hospital is? How are things going to progress? Which patients are at higher risk? How would that affect staffing and so on? So it's less on which patients do we prioritize, I think the ethical issue that David was raising earlier, but rather how much resource do we have to put in to ensure that we cope with the capacity, with the demand that's coming? So it's looking from the other end. So that data set essentially required the pseudonymization process that we're talking about, but also that's one of the first data sets that went on a platform that we call the Trusted Research Environment. I've been talking about all these data so far. The last thing you want is for any of that data to sit on someone's laptop or even on a university server. unless you have the very adequate security processes in place and training for your staff and everything. Essentially, assume that everyone is a moron and everyone will screw up at some point. So put all the safety nets in place to ensure that the data is protected. So the data, it's essentially a patient that you're protecting at that point. So in my ideal world, there are trusted research environments all over the place. Every researcher has access to it. They're all fully trained, understand how data governance works, and they're pretty much hundreds of fail-safes in place to ensure that data leaks and breaches don't happen. But in the event where data breach does happen, everyone also knows how to report and how to follow up to ensure that impact on data, the trust, and the patient ultimately is minimized. But the assumption is that common sense doesn't exist. Always ensure that all processes are in place so everything is as safe as it gets. So, for example, for the current work I'm doing, the trusted research environment sits in a data warehouse in Liverpool. And they have the high security in place, and very few people can access that data. And we know that it's physically in England, which is part of one of the requirements for the trusts, and only trained and authorized users can access, and they can only access based on DPIAs and information sharing agreements that have been placed for each of the projects that they are running. So the data is safe, possibly even safer than they were in the trusts themselves. So then the final question set is how to connect the data from NHS to resource like BEAD to be able to do AI. I have no idea because I still can't think of how we can make sure that BEAD is as secure as it gets to be able to look at patient records. I can definitely see how we could work with BEAD for image processing, for example, but I don't know how to do that for patient records. Sorry, we already did the second bullet. And then if we move to, well, the next two bullets, David has definitely addressed it, and I think he's the expert, and that's the thing to follow. But I also gave you my reflections around the TRE. And then the last one, when you do a DPIA, you always do a DPIA. Essentially, even if you're going to just download data from a website, just pretend you're doing a DPIA and make sure that you have the right processes in place. Be a safe researcher. I think that's the key point. So I was assuming you need a DPIA. When everything really broke in my mind was when I had to start doing COVID research. And I joined the data cell for the local resilience forum for Durham and Darlington, and they wanted help with COVID modeling. You would think that in a data cell where you have the local authority, you have public health, you have the trust, you have all the emergency services, data access wouldn't be a problem. But data access was the biggest problem for them all, even for them to share data between them. They needed to be able to identify the populations that were at risk. They needed to be able to ensure that the services, especially the emergency services, knew who the highest risk people were, and they couldn't tell each other who those people were. It was the most absurd situation we've been at. We started seeing the bodies piling up. We were at the point that we needed to predict morgue capacity and whether there would be enough burial sites in place. It was probably the worst month of my life. And I never want to be able to need to do that again. But that was the point where you saw that the inability to share information was actually causing harm. And that wasn't just in Durham and Darlington, that was in all local authorities in the UK. There were other mechanisms that were put in place to improve data sharing, not just with researchers, but between different bodies. Eventually, data sharing has improved, but it was definitely not as good as you could have expected. It took a long time for local authorities to even be able to understand who or where their cases were, and all they could see were the deaths coming through, or the hospitalizations. So that was the most disjoint process I've seen so far, and it shows that we do not have resilience in the UK to handle a pandemic. What the trust and the local authority then asked the university was, can you create models that can help us understand the process, the pandemic process, and how different policies and interventions can help or would impact the different decision-making processes that we have to take. So in particular, hospitalizations, any morgues, and so on. So that's what they needed to understand. So we had to go back to the basics. Don't assume we have patient data, because we don't. Not even the trust knows who the COVID patients are at that point. And then we just need to go back to the basics with a mass model, where you're looking at the progress of the pandemic through your population. And when we started that modeling exercise, only national models were in place, and we really needed to understand the dynamic within the Northeast, but in particular Durham and Darlington. So we started, but we started from the policy side. We wanted to understand what the local authority and the hospital needed. A lot of people at that time in 2020 started from, I've got all the case data, or I have some case data, I can simulate the dynamics and so on, and here's my model. And then you have all the dodgy models that David was talking about. You don't start that way. You start by talking to the people that will use your model and understand why they need the model, or whether they need the model to start with. And then you build in the strategies that they need to be able to understand. And they also will have a lot of knowledge about what's actually going on within their own population. So you never start by putting a model in front of the stakeholder. You talk to them first, and then you build a model. We identified what the main issues were. So the number one issue for Durham and Darlington was the blocked bed effect. Essentially, COVID was essentially taking all the beds we had in place. We had shielding. We have a very large elderly population, so shielding was in place, as well as many people with long-term conditions that fell on the shielding list. Quarantine, it was a very political issue at the time, and even how test and trace worked before even test and trace was a thing, the whole app and so on. So the key was trying to present scenarios that allowed the local authorities and the hospital understand what the potential effects of different measures would be. I'm not going to present all of them here, but that's all of what we created was based on what they needed rather than what we wanted to produce. And what they needed to know is how many deaths, how many hospitalizations, how many cases are going to be in ICU. I mean, number of cases, yes, it's interesting to know, but that's not the important thing. And how do, for example, if we start a comms plan that could lead to reduction in activity, so people staying home at different levels, how would that impact the short term and the longer term effects of the pandemic? So that's what they wanted, which is very different normally what academics want. Anyway, so we looked at different questions, and what in the end was most useful for them was a matrix that looked like what the proportion of compliance in terms of isolation was versus the proportion in compliance around activity reduction. And then when they started looking at activity reduction was how do you enable activity reduction to take place, and how can the emergency services support that, and so on. So that was the key. That was the question they were asking. So you should always be working with your stakeholders and delivering what they need, not what you want to deliver. Sometimes what you want to deliver is also the right thing, but you have to make sure that they're going with you. And that way you actually have access to data, and even more valuable data than patient records, which is the expert knowledge and interest as well on how policy will be built. So that was, well, that is still part of my life. But this is what we were presenting back in mid-2020, so people could understand where we could go as a county over the next few months. And then I can talk more about other projects I've been involved around COVID, but I would say that sort of addressed all the questions that had been raised before. And I'm happy to talk about other experiences or more specific questions as well. So hopefully that didn't contradict David too much.
I just say, no, it complements what I said remarkably well. It's good to see the real world issues beyond those that are actually aspirational.
Thanks, thanks, David. But I think it would have some value for us to actually put a presentation together talking about both sides, I'd say. Anyway, any questions from anyone? Right, so your question starts slightly the wrong way. Your model never makes a decision, never build a model that makes a decision. You always produce models that offer decision support and offer different scenarios that ultimately a human will make the decision. Do not build a model that makes decisions. Then you're in a complete different world where, I don't know, probably 1984 happens, I would say. But also, whenever you build a model, make sure you build it with experts alongside you. Don't build a model without support. I mean, I guess the other side that often forgotten when building grant applications, it's not just the environment you need. You need to ensure that, for example, Catherine, who's here on the call, she works in the policy team in Durham. A lot of her time has gone into help setting up the governance structure. At some point last year, when we were working with all the local Northeast trusts, we had about 14 people working on the build-up of the information governance structure that would allow the data sharing and the use of the TRE. Essentially, the technical implementation of the TRE is not the problem. It's all the paperwork that goes around it and the assurance that need to be in place. So I think people normally underestimate the amount of work that goes into building the structure. Newcastle had exactly the same issues. We were exchanging documents for quite a long time. I don't think that any direct ethical considerations, at least on the work I did. There will be ethical considerations, especially if you're talking about neural nets or random forests or any other deep learning type algorithm, because you are incorporating data in your training process. That wasn't the case for what I built. I think that's probably the best way I can answer that. So the one time I had to handle that was actually during COVID. The hospital in Manchester that I was working with, they wanted to capture more of the information within free text. So without the, I don't think I have a better term, but you need data monkeys, essentially. You need clinicians and trainees. They're willing to sit and look through all the records and code that data for you. That's the best way, because you're talking about paper records most of the times here. These people are going to have better access to the data, and they'll also be better interpreting that data. If we're then moving at actually free field typed data, then, for example, the mental health trusts are crying for help to be able to code those in an automated way. And you can't really have someone sitting through every set of notes and coding them. There are serious implications around the research that can be done around that, but there would be incredibly value if someone could put a process in place that was definitely ethical and ensured privacy of the patients. But I haven't seen that yet. The only time I had to look at that was when the mental health trusts approached us to look at exactly that natural language processing techniques that could be used to understand what was encoded but not coded within the text. So because coding in mental health can be incredibly hard, and sometimes the consultant just doesn't have the time to do it. So can we automate that? And at no point the trust I was working with even considered third party because they just did not want the data anywhere near a third party.